So, depending on the age of the patient, especially if they're geriatric, there are issues with opioids. Everybody's different with opioids, meaning if they've never had them before, we don't know how they're going to react. Um, Other issues are how's their renal function doing? How's their liver function doing? Some pain meds, opioids, you need a good liver and a good kidney to metabolize these. These will build up. So elderly patients, for example, usually a lower dose will go a long way. Um, do they have a history of substance abuse? If a patient has a history of substance abuse, they need more opioids, pain meds, to control their pain. That's just a fact of life. A lot of physicians, they're not, they don't aren't aware of that, and they just think, oh, they just want more pain meds because that's just the way they are. Um, Elderly patients that have a lot of medications, there's interactions with opioids. You need to be careful when they have a lot of pain, a lot of medications. Also, the route of administration, um, by mouth, by IV, by epidural, PO. Um, some people tolerate different methods better than others. No two people are the same. Some patients, it doesn't matter what the opioid you give them, they will be nauseated and vomiting with every pain med. Others have no problem with that. If they do have a problem, then we have meds, antiemetics, Phenergan, Zofran that we can give the patient. So lots of issues with opioids, not two are alike. Um, and people will respond differently with each one. Chronic pain management issues. Most pain management is difficult to manage by any doctor because the doctor's not been trained. That's why we have pain specialists out there now. In the hospital, these people are wonderful. If a doctor turns over pain management to these doctors, oh my gosh, you just see immediate results. Lots of pain management issues. The dosages have to be titrated. We have to use different kinds of medications. Um, some pain management patients will not be pain-free. So we need to find out what their baseline is and what they can perform and what they can do. So being able to do a lot of your LDLs, ADLs, maybe not a couple, is better than having the pain and you can't do any of them. Pain management is the fear of the side effects. Everybody thinks they're going to become addicted. Um, the other thing is pain management, especially on the floor. If someone's on palliative care, people are afraid, nurses are afraid that if we give too much, we're going to kill the patient. We don't kill the patients by giving pain meds. We keep them comfortable. There's a double effect on palliative care that we want the patient to be comfortable. Will that pain med kill them? No, it usually does not kill them. It may ease their comfort and maybe they're at the point that they're probably going to die, but it does not kill them. So that's not there, and that's usually a fear that people have. PCA, patient-controlled analgesics. These are used a lot more than they used to be. Very common in the hospital. Lots of patients, depending on the doctor, every type of surgery the doctor does, they'll have a PCA. Patients can control that. They've done studies that shows if a patient is in control of their analgesics, they have better pain control. The number one thing you need to teach the patient is they push the button, not the family. If a patient is opioid naive, meaning they've never had the opioid, we don't know how they're responding. We may need to titrate the pain med up or lower it because we don't know what the sedation level is, what the respiration level will be. These are the things we need to monitor. So patient controls it, family does not hit the button. Usually we find if a patient can control this, they don't hit the button and receive as much pain medication with this than if we were giving them boluses. IV boluses. We'll talk more about PCA next time. So arthroplasty. Patient is transferred from PACU at 1400. It's 2200. The nurse notes that the client has not voided. Orders include IV D5.5, 100, morphine 2 to 4, every 1 to 2, CBC in the morning, continuous passive movement. The best action for the nurse to take at this time is insert a Foley catheter to drain the client's bladder, get a bladder scan and insert a straight catheter, assist the client to stand at the bedside and provide the urinal, position the client on his left side and provide the urinal. What are we going to do with this patient? Right, the right answer for this one is, let's try C. Let's always do something least invasive before we do something invasive. Have the patient stand up if it's a male, get the water running, give them some privacy, things that are going to help the patient urinate. Urination could be a problem from opioids or from surgery. An adult client had a bunionectomy under epidural block. In the immediate postoperative period, the nurse plans to assess the client for side effects of the epidural that include which of the following. Select all that apply. Complaints of headache, paresthesia in lower extremities, hypotension, urine output at 30 to 40 mLs an hour. You figure out this one for an epidural block. Client is scheduled to be discharged from the ambulatory surgery center following an umbilical hernia repair. Client must meet which discharge criteria before leaving the center? Select all that apply. The client is scheduled for conscious sedation for a colonoscopy. Which post-procedural nursing assessment would be a priority for the nurse to perform? Assess pain using 1 to 10 scale, assess respiratory status, assess level of consciousness, assess orthostatic hypotension. During recovery from anesthesia in the post-anesthesia care unit, a client's vital signs for the past hour have been blood pressure 112, 110, 112, 114, pulse 76, 78, 78, 80, and respirations 22, 24, 24, and 26. SpO2 85, 82, 86, 97%. The client is sleepy but awakens easily and is oriented when spoken to. The client's surgical dressing is dry and intact. The most appropriate action by the nurse is to change the client's position to the lateral side, notify the doctor that the patient is ready for discharge from PACU, check the client's temperature and apply warm blankets, encourage the client to take deep breaths.